Hello, everyone. My name is Haranjan Lalli, and I am with the new Brampton Community Task Force as their CAO. And I have with me Mr. Dave Kapil from New Brampton Community Task Force as well, and Dr. Supriya Sehgal all the way from Dallas. She's a rheumatologist out of Dallas, and we'll be talking on, obviously, COVID-19 and what are the current updates medically, socially, economically, and politically. So let's get right in it, guys. First question that I have, maybe Mr. Kapil, you can take that. How do you feel about the U.S. opening up? Like yesterday, we know that a lot of changes happened. Should Canada be doing the same?
Oh, absolutely not. I think, in my personal opinion, absolutely not. What the U.S. is doing is like absolutely crazy. It's very dangerous what they're doing, in my opinion, because really nothing has changed in the last 3 months. There is no vaccine, there is no medication, there is not adequate testing done yet. They're opening up just because the curve is flattening. Well, what curve is flattening has got nothing to do with the amount of deaths you're having. All that means is people are locked up and you're having less deaths. That's it. Less cases as a result. That's all it's changed. The minute you open up, everybody goes back out and it starts all over again. And this time is going to happen 1,000 times more than it happened last time. Because when it started before, it started by one person and it went to 10 and 100 and 200. Now we already have millions of people infected and possibly infected. And we have only tested 1% of the population. So to me, this is absolutely crazy what's happening in the US. Like Canada, absolutely not. They can't even think about it.
Do you feel that US opening up is sort of like a short-sighted political decision?
Absolutely. I think so. And would you agree with me? Because Dr. Sehgal, I don't see anything changed that gives them a reason to open up. Am I missing anything?
I would like to add to that, from a medical perspective and just from a data perspective, to lift social distancing restrictions, you need to have a few things in place. You can't just be on the downside of the curve. Okay, that's not enough because you don't actually know what the rest of the curve looks like. So the curve could look like this. Okay, it could slowly taper off. It could be sharp, but it could even look like this. And so what you really want to see before you lift social distancing measures is a prolonged, flat, low incidence curve. So not here, but down here for a long period of time. And each government is probably going to decide where, how long it has to be before they lift those, those restrictions. But flattening of the curve, or even just, complete suppression of that curve, which is, in my opinion, really what we need to be aiming for, is only one part of the picture. You need to also have reliable, immediate identification of cases. And when I say reliable, I need a test that is going to be extremely sensitive. So in the US,
I want to ask you, we have the current numbers on the screen, whatever's going on globally in US and in Canada. How reliable are these numbers? When we talk about the testing and we talk about its reliability, can we even trust these numbers?
So again, epidemiologically, because this is a new disease that has hit the population, we need time to get our data. So that, we've had limited testing. Again, in a lot of countries, that is becoming more widespread. But there is going to be an underestimation of the number of cases. Also, quantifying deaths is going to be an issue because, up until April 14th, I believe that deaths in home were not actually being reported as COVID-related deaths. Now, the CDC has updated their website or their recommendations to include all, not just documented but probable COVID cases as, listing them as deaths. But you can imagine how many cases we missed before we had that, addendum put into the guidelines in terms of.
So we can't really say that we've actually reached the peak and the curve is flattening because we don't really have the accurate numbers yet. So
That's true, and that's going to affect the model. But the other thing is we don't actually know what the rest of the curve looks like. So you really do want to see suppression for a prolonged period of time. We really do need to make sure our testing is very widespread. We need to be able to test large numbers of people, and not only symptomatic but asymptomatic people in the population, to identify outbreaks quickly and accurately, and contact those people and isolate them efficiently. And that's really what needs to be done. And people are talking about serological testing, and yes, I absolutely agree that we need to do serologic testing along with the rapid test. But serologic testing, which is where you check for the antibodies, those antibodies take time to convert. And so to me, that's not enough of an immediate test to determine if an outbreak has occurred.
Again, you want to add something to that, and how long do you think we have to wait on a reliable test, or how long do you think this whole story is going to last?
There's really no way to predict that right now. I mean, right now the FDA does have a lot of tests coming in and are awaiting approval. Some of them are getting approved under what's called EUA, which is an emergency use authorization. Our concern with that is, of course, if we're rushing to get the tests pushed through, which I understand we need to do to a certain degree, how good are those tests? We haven't perfected them yet.
Mm-hmm. One of my issues is what I'm having a problem with this opening up in US is, to me, nothing has changed. Like, there is no solution yet in sight. And the only reason your curve has flattened, the only reason it is flattened is because people are behind closed doors. So people are not being exposed to other people so they can get infected. So that hasn't changed. So how do you expect opening up is going to change anything? All you're doing is all those people are coming right back out who are infected, who are isolated, or who are not infected. Some people come out and they infect these folks. And then you have a huge number, and suddenly now you're going to shut everything down all over again.
So we could really potentially look at a second surge of the numbers, if these numbers are even correct.
Absolutely. I'll give you an example. A friend of mine owns a restaurant in UK. And when they had to shut this, because of this, they had to shut the restaurant off. Thousands and thousands of pounds worth of food was wasted because they just had to shut it off completely. In their case, they don't do takeout, so they have to shut everything off. Now just imagine you open your restaurant back up, you buy all that food all over again, you bring all your waiters in, you bring all your chefs in, you set everything all up, and then a month, 2 weeks later, you have to shut everything back out.
Yeah.
And now you got a bigger problem than you had before to begin with. So people need to understand that. So folks who are, putting pressure on our leaders, on our politicians to open it up, they need to understand this. This story needs to be explained to them. That thing has really changed. It just, by flattening this curve, all it's done is it has given the medical community to come up with a solution. It has bought them a bit of a time. People, the death rate is not increasing. That's all is done. Am I missing anything,
No,
Dr.
no,
Sehgal?
I agree with that. And, to that, I also want to, add about just how quickly this can spread, and how we're talking a lot about asymptomatic transmission, so this isn't a disease where somebody can have symptoms and we can test them and, okay, the test is positive and we can isolate them. That would, that'd be great. But the fact of the matter remains that some studies are showing 50% of patients are asymptomatic when they are COVID-19 positive. And also 44% of the time in patients, an index case when they're transmitting to another person are doing it during what we call their pre-symptomatic phase. So you can see the logistic nightmare here, in terms of you can't just test symptomatic people. It has to be contact tracing and, almost a universal contact tracing policy where we have to sample the asymptomatic people too. And because of that, that puts us at a high, that those asymptomatic patients, I am concerned about the risk of a surge, just like what you're saying. And, we need to make sure that if there is a surge, and when you lift social restrictions, of course there can be a surge at any point in time, but worse with lifting social restrictions. If we do that, do our hospitals have the ability to manage a surge properly? Now, I do see that there's been a lot of effort here to do surge protection, and I appreciate that. But at the same time, you need to be absolutely sure that every hospital, every healthcare, facility in the population that you are lifting social restrictions on has the capability to manage a surge. We cannot have patients that don't have enough access to ventilators, pulse oximetry. We need to make sure that there's enough PPE for surges as well. So there's really a lot that needs to be in place before you decide to lift social restrictions.
Sorry, go ahead. Go ahead.
For me, what worries me the most about opening up, if you're not prepared, is it is going to take you probably 15 days to realize how much you've screwed it up. At least 15 days. Everything is going to be beautiful for 15 days. Nothing is going to change. Because all the folks which came out, now they're spreading the virus, and it can take up to 15 days minimum before the next guy, before they know that somebody has picked it up. In 15 days, you have multiplied cases. Like, look at the cases rate right now. They're jumping, they're doubling every second, third day.
We could expect a surge in a couple of weeks, is what you're saying.
And not a couple of weeks, it'll be an exponential surge in a couple of weeks.
Mm-hmm.
So you are certainly seeing, for example, 1,000 deaths a day, happening somewhere. And now 15 days later is going to go from 1,000. It won't take 15 days. It probably will take maybe 25 to 30 days when the 1,000 goes to 20,000. And it's too late. Am I right, Dr. Sehgal?
I am also concerned about that because of the level of asymptomatic spread.
Dr. Sehgal, talking about medical preparedness, do you're keeping pretty up to date with whatever research is going on in terms of vaccines and medicines. Could you shed some light on what exactly is going on in terms of getting a vaccine ready? And I know there's various medicines that are being tested. Could we talk about that, please?
Yeah, sure. So basically there's a lot of vaccines that are undergoing trial right now. There's one in the UK that is entering a phase 2 trial to my knowledge. There's two in the US, and one is, an NIH funded vaccine that, last statement I saw in that they're hoping that that's going to be ready in the fall, and for healthcare workers, and then ready for the population in the spring. China appears to also be, undergoing vaccine trials as well. So, I can't tell you right now at this moment, I wish I could, but I can't tell you that the vaccines are going to work. Okay, we have to test them. We have to make sure they're effective, and we have to make sure that they're safe.
So what you're saying is, even if there's an effective vaccine that comes out, we're looking at least next spring.
I would say that that's realistic. Yeah.
What about this medicine named remdesivir? Are there any positive results out of that? And are we looking at like a controlled testing on that?
So for remdesivir, we are undergoing randomized control trials right now. We do have a study that was published in the New England Journal of Medicine. It did not compare people who took the drug to people who didn't, but it did kind of look at clinically people who took the drug and compared it to the rest of the population, to the population data at that time. And it showed some good clinical results. So, again, nothing beats the randomized control trial, but it's nice to see that what they documented was that the drug improved patients clinically, as opposed to in a test tube or a lab. So I really like seeing the clinical improvement, but again, we do need that.
Okay, Dr. Sehgal, what do you think about this malaria combination medicine? Do you think it's looking any positive across US? I know US has been testing it across.
So, that was one of our first that was one of our first drugs that came out. And, we were really hopeful that it would be very effective. And there was a French study that showed some improvement. Actually, it showed what they thought was remarkable improvement in patients that were taking Plaquenil. However, that study did not compare it to a control group. Okay, and they basically seem to have only looked at outpatients. So it doesn't really, we have no way of knowing if people got better because they took the drug, or if they got better just because statistically they got better on their own. Now, there is at least one randomized control trial that I know of in the US, that's undergoing investigation right now, and it's but we don't have data on that yet. There is some concern that the Plaquenil or hydroxychloroquine azithromycin combination may actually be an issue from a heart rhythm perspective. So some of the EP or electrophysiology, cardiology people that I've heard from are actually basically monitoring those patients on a heart monitor because they're concerned about rhythm problems with the combination. So you can see how, that's a great example of how a drug can look great initially, but as it undergoes vigorous testing can fall out of failure. And that's why we really do need the randomized control trials. I'm hoping it shows some clinical improvement, but again, we need that data.
I would like to probably add that, like a lot of these prescriptions are fairly easily available in India, from chemists and things. And a lot of our folks are used to just buying medication off the counter in India, or telling their relatives and friends, just buy it and mail it to me. Please ensure that you don't use that medication without your doctor's prescription.
I absolutely agree with that.
Yeah, so
Dr. Sehgal, we've heard about the term herd immunity. Could you explain what herd immunity is, and do you feel that that could be our solution?
Okay, yeah, that comes out a lot, with this pandemic. The idea that, so basically herd immunity is that somehow by infecting enough people, by enough people being infected, we can protect those people who have not been infected with the disease yet, whether because the infected people had developed antibodies, or because they got vaccinated. But the idea being you cannot transmit the disease through the population because enough of them are immune to it that they can't pass it on to somebody else. And so indirectly, you're protecting those either non-vaccinated patients or patients who haven't been exposed to the disease and developed antibodies. So here's the problem with herd immunity with COVID-19. First of all, we're making a big assumption by assuming that because we have testing for antibodies and we're seeing the long-term antibodies show up on the test that we have immunity. That may not be true. We don't know how much antibody you need to protect yourself long-term from the disease. We don't know how long that, what we call IgG, but the long-term antibody lasts. So for some coronaviruses, that long-term immunity only lasts a few months. And so how can we make that big assumption that we are protecting the population if that immunity only lasts a few months? And third, sometimes other coronaviruses can cause that test to be positive. And so we don't know how many false positives there are on that serology. So, from just a technical standpoint, you can see the problem with herd immunity. We can't talk about vaccinations because we don't have one, so that's out. But let's talk about the human side of herd immunity. If WHO is talking about a 3.5% mortality rate from this disease, and let's say 50 or I guess the estimate is 24 to 70% of the, and I'll bet it's more, but you know, the last estimate I saw was 24 to 70% of the world population gets this disease. We are asking that many people to get infected and 3.5% of them to actually die. I mean, that's, we can't have that.